I'm Heather Hsu. I'm an assistant professor at the School of Medicine, and I'm going to be talking about from mandated reporting to mandated supporting, a project on building the evidence base for best practices and assessing protective concerns for substance-exposed newborns. Just to start out, this is a photo from the Boston Globe from about a year ago. It's a Massachusetts woman named Kayla Ford and one of her 3 children. When Kayla was pregnant with her first child, she was using heroin and knew that she needed help. She was able to access care, got started on a medication for opioid use disorder, which worked really well for her. When it came time to have the baby, she had been in stable recovery for 6 months. But the clinicians at the birthing hospital where she gave birth reported her to Child Protective Services because of the substance exposure to her newborn. Same thing happened when she had her second baby. Same thing happened when she had her third baby. At this time, she'd been in stable recovery for 6 years. And so reflecting on this experience, in the article, Kayla said, the social worker said to me, I don't even want to report you, but they make us, I have to. I remember toward the end of my 3rd pregnancy being terrified that they were going to bring CPS back into my life. I was thinking about that more than the delivery. So this quote from Kayla really highlights the tip of the iceberg when it comes to the harms of mandated reporting for prenatal substance exposure. So we know that access to effective evidence-based treatment for birthing parents with substance use disorders promotes parent, child, and family health and reduces risk of harm. Mandated reporting presents a really big problem in that it anchors evidence-based care, like birthing parent use of medication for opioid use disorder, to systems of family surveillance. It also increases risk of relapse, substance use, and overdose. It doesn't have any medical benefits for the baby. And we also importantly know that there's a hugely disproportionate risk of consequences for families of color in terms of engagement with Child Protective Services. But it doesn't have to be this way. We at Boston Medical Center back in May 2021 implemented a new clinical guideline to inform our Child Protective Services reporting practices. So historically, most birthing hospitals, especially here in Massachusetts, have interpreted our state and federal laws as requiring clinicians to report, to make a Child Protective Services report automatically in any case of prenatal substance exposure. We moved beyond this at BMC and chose to try to focus more on substance use treatment engagement and trauma and justice-informed care, and file a report only when there are tangible concerns about a parent's ability to safely care for their child. We did an analysis of 17 birthing hospitals in Massachusetts, including BMC, and found that BMC was able to cut our reports in half with no unintended consequences related to custody at discharge or a newborn length of stay. So to take the next steps in this project, my research team is working on a proposal to NIDA to try to look at more longitudinal outcomes of this type of guideline change, because after BMC made their policy change, Mass General Brigham decided that they could follow suit. So we have a number of hospitals in the state where we can look at this. And then in addition, we would do mixed method study of facilitators and barriers to guideline change and develop an implementation toolkit so that we could spread this work nationally. So please let me know if you have any interest in joining us.